Okay, guys, thank you for attending. I was tasked to talk about non-invasive approaches to differentiate between SVT mechanisms. And these are my educational platforms for you guys to check out. Okay, so the outline for this presentation would be first of all, we will classify SVT based on the on clinically relevant mechanisms, and then we'll discuss ECG hints to favor a specific type of SVT and mechanism. Okay. And then we'll also talk about adenosine being diagnostic and or therapeutic for for tachyarrhythmias in general. Okay. So guys, try to be interactive, but be quick because we have a couple of, we have many slides and we should be done within 30 minutes. Okay. Okay. So, so first of all, SVT is defined as any tachyarrhythmia that originates from at the His or above the His, and includes regular and irregular atrial tachycardia, regular AV and AVRT, and AVNRT, in addition to junctional tachycardias as well. Um, so clinically relevant mechanisms for SVT is, we did talk about this before, reentry, or reentrant SVT, which is characterized by a sudden onset tachyarrhythmia with sudden termination and often very regular. Okay. This is a telemetry heart rate tracing of a patient of ours in our unit. And as you can see, there is an abrupt heart rate change and then persistent regular heart rate and then abrupt heart rate slowing. Okay, guys? So this is characteristic reentrant tachyarrhythmias, okay? And examples of a characteristic reentrant tachyarrhythmias are atrial flutter, AVNRT, atrioventricular reentry tachycardia, both of which are adenosine responsive, the AVNRT and AVRT. And again, just really quick, AVRT just means you have an accessory pathway, and the tachycardia goes down the AV node up the accessory pathway, or it could be the other way around, but very unusual or rarely, in which the tachycardia goes down the accessory pathway up the AV node. Okay. And other clinically relevant mechanism for SVT is automatic or focal tachycardia, in which there is gradual onset and gradual offset of the tachyarrhythmia and is often irregular. And then examples are atrial tachycardia or junctional tachycardia, okay, in which you have one focus that is firing, often irregular, and often the onset is gradual and the offset is also gradual. It's not 100%, rule, but very common. Okay. Okay, so we'll simplify things with by showing ECGs. So this is a 7 years old a patient who's tachycardic since birth, and recently he was on combination of beta blockers and flecainide, and he was recently advised to stop medications and see what happens. And then the patient had repeat tachycardia or palpitations, and this is the ECG. So, guys, really quick, really quick. How do you describe the ECG?
It looks sinus tachycardia.
Okay, I heard sinus tachycardia.
Yeah,
First,
there is some B waves
yeah.
in C1, C2, C3. It's here.
Okay. So I heard, I mean, definitely tachycardia for age. I mean, heart rate is maybe 170, 180. But the question is it, first of all, so tachycardia, narrow complex or wide complex?
Looks narrow.
Narrow complex, regular. So I would say
Regular.
regular, narrow complex tachycardia. The next question would be, is it sinus tachycardia or is it something else? So Smile is saying sinus tachycardia. Anyone, like everyone else, are you guys in agreement or disagreement?
Some B waves not clear. Sinus.
I understand you're saying there's a P wave here before the QRS in V1, V2,
Mm.
and so forth. But um,
Some deflection. Inverted B wave.
where? I mean, guys, so in order to tell whether it's sinus tachycardia or supraventricular tachycardia that is not sinus, you have to study the P waves, of course, right? And the P
Mm.
waves in lead one, are they it's like the P wave in lead one is sinus or non-sinus? The P wave in lead two is sinus or non-sinus? I mean,
Uh,
if you really
looks inverted.
yeah. So the P wave is maybe flat in lead one,
Mm.
but definitely inverted in lead two, three, and AVF. Okay. So is this still sinus tachycardia or no?
Jet.
Well,
هتبقى jet.
it's not sinus tachycardia, right?
Not sinus, yes.
Okay. So I was hoping that you say narrow complex regular tachycardia with an abnormal P wave axis, okay, with one to
Mm.
one PQRS ratio. So when you recognize this, these are
Mm.
the inverted P waves, by the way. So this is how you should approach
Yes.
the ECG. So this is tachycardia, narrow complex, and then if it's sinus, you should see normal P wave axis, which is positive in lead one, two,
Yes.
three AVF. But if it's abnormal P wave, then immediately you just say SVT, because SVT
Mm.
just means you have tachycardia that is not sinus. Okay, narrow complex
Mm.
tachycardia that's not sinus. And I mean, SVT, of course, could be also white complex, but for narrow complex rhythm, if you have tachycardia that's narrow complex without a normal sinus P wave, then it's an SVT. Okay, then next question would be what type of SVT. So anyway, so this is an example of an SVT, and then thereafter, next step you should do is then study the RP interval. Okay, if the RP, to simplify things or narrow your differential, if the RP interval, so the onset of the Q or the onset of the QRS to the onset of the P wave is longer than your PR interval, then this is by definition called long RP tachycardia. And then you have basically narrow differential diagnosis. You guys remember what's long RP tachycardia differential diagnosis? We had discussed this in the past, but probably many months or years ago. So probably you guys had forgot, but really quick. So you could have something called PJRT, okay, which is a slowly conducting retrograde accessory pathway. It's a type of AVRT, or you could have atypical AV and node reentry tachycardia, or or another difference would be atrial tachycardia. Okay, so like we previously said, AVRT and AVNRTs are usually adenosine responsive, and atrial tachycardia is usually adenosine unresponsive and irregular. So this is so when you have long RP tachycardia, then you have a narrow differential, and then you look at the regularity of the tachycardia, you look at the PQRS ratio, and you look at the adenosine response, and then you can narrow down your differential even further. Okay. Sinus tachycardia is also a type of long RP, but again, the P wave should be normal in axis. Okay, so this patient underwent ablation, and the patient was having PGRT type AVRT and was ablated thereafter. Okay. Anyway, so there's another patient who was also complaining, who's a couple of years old already, but also complaining of palpitation that is recent in onset. And then really quick, guys, how would you describe the CCG?
B wave not clear here. This looks junctional.
Well, just say,
Junctional
describe it.
tachycardia.
Just describe it. Just
Mm.
say narrow
Yes,
complex, yes or no? Narrow complex tachycardia, right?
سيناريو كومبلكس.
Narrow complex.
لا يعني
I mean, the QRS duration is what? The QRS duration is definitely less than 80 milliseconds, صح?
yes.
Okay, so narrow complex, regular tachycardia. Okay, again, do you see P waves that are sinus or no?
لا not sinus.
Not sinus. So when you say now, when you see narrow, complex, regular tachycardia without sinus P waves, what would you call this? We just said
narrow complex.
narrow, complex, regular tachycardia and non-sinus P waves. What is this? How do you call this? ECG?
مم.
So back to our algorithm.
لسه
Tachycardia, narrow,
اه
complex, not sinus. Then what?
SVT.
SVT. Okay, so that's another SVT example. And then next step would be assess the RP interval, صح? Remember? So in this case, the P waves, do you guys can clearly see a P wave or very difficult to see? I mean, can you identify a P wave with confidence? Well, difficult to identify a P wave with confidence.
معلش دي يا دكتور محمد هبقى معاكم بس دي واحدة.
Okay, guys, ميرفت متولي سحر كل اسماعيل مسكين. عباس ما ادري اذا موجود ولا لا.
Well, we cannot identify B
Okay,
wave.
thank you. Okay, so you cannot identify P wave with confidence. So it's an narrow complex regular tachycardia with an abnormal P wave because you cannot identify it being sinus. So this is also called SVT. Okay, so that's an SVT. Then we would say because you want to study the RP interval, but you cannot see a P wave very clearly. So I mean, if you look very, very, very carefully, I wonder whether there's a P here at the end of the QRS. It looks very suspicious, right? I'm zoomed in here. Okay. Okay. I wonder. Okay. To my eyes, this looks like a P wave, but difficult to be 100% sure. But
فين يا دكتور محمد معلش فين؟
the one that you see this.
اوكي.
Okay, anyways, so the patient received adenosine, and then you have an ECG after adenosine, and then the patient goes back into sinus rhythm, right? P wave being pulse in lead 1, 2, 3, and AVF has a little bit of left axis for whatever reason, okay? But then if you look carefully at this segment, okay,
مم.
if you remember, there was a blip here, but you lose that blip here, okay?
مم.
So then perhaps this was indeed P wave, okay? Because if this was part of the QRS, you should still see it here, right? Okay, guys?
مم.
So then this patient probably had a short RP tachycardia, meaning the RP interval is definitely shorter than the PR interval.
مم.
Okay? So then this is a short RP tachycardia, and differential diagnosis is even further narrowed down into AVRT, which is typically above 50 to 70 milliseconds from the QRS onset, the P wave, I mean, or typical AVRT, which is typically very short. The RP is very short, or even, and it's super short sometimes that you cannot even see a P wave. Okay. Anyways, so studying RP interval is helpful to differentiate between SVTs. Okay. Uh,
Yes.
okay, and that's an example of RP interval that is still short, but longer than this RP interval. Okay. Anyways, these are details that you might not be super duper necessary for regular cardiologists, but for those who are interested in electrophysiology, it's definitely important. And the reason why it's short RP, very short RP in AV node, because remember that tachycardia is within the AV node, and then you get a ventricular activation and atrial activation at the same time. Okay, it's a circulation that is in parallel. Okay, so you get very short RP interval. Okay, QRS and P happens at the same time. Versus when you have an accessory pathway, of course, you get the QRS, and then later you get the P wave. Okay, because the accessory pathway conduction is usually rapid, it's not super later, it's a little later. Okay, unless you have a very slowly conducting accessory pathway, then this is called PGRT, and you have long RP tachycardia. Make sense, guys? سحر اسماعيل متولي ميرفت. make sense.
يس.
اوكي. اليوم اسماعيل انت النجم،
Yes.
الباقي نايمين.
لا ده في المستشفى خفار.
اوكي زين. المهم
تمام.
تمام. Okay. So we talked about tachycardia being narrow, and then we said how to differentiate between sinus tach, and you have only two differential. It's either sinus tachycardia or SVT. Okay. And then
يس.
when you think it's SVT, uh,
اللون.
and by the way, when again defining sinus P waves, P wave axis should be normal, like we said. Lead 1 and 2, 3 AVF should all be positive. Your sinus rate is typically 220 minus your age. It's usually, if someone is tachycardic with fever, with pain, with anxiety, it's expected. But if someone is resting and heart rate is very fast, that's against sinus tachycardia, of course. Usually the onset is gradual and the offset is gradual and so forth. Okay. And it's usually one-to-one conduction. Okay. Anyway, so back to
Yes.
SVT. Then, you can differentiate SVT into regular and irregular SVTs. And like we said, regular often is reentrant SVTs. And then the
Yes.
regular SVT is subdivided into AV, NRT, AVRT, or flutter. And then RP interval helps you differentiate between various AV NRTs and AVRTs. And then with Flutter, often you have more P's than QRSs. Sometimes difficult to be sure, but typically you have more P's than QRSs because the the atrial rate is usually rapid. It's so very difficult for the patient to conduct one-to-one. Okay, and here's an example. So this is how do you describe, guys? So let's call this ECG number 1, okay? How would you describe this ECG? It's a limited tracing, but just really quick. How would you describe it? I don't want diagnosis, I just want description.
Also narrow complex tachycardia
Thank you.
with no clear P waves.
Thank you. So it's a narrow, complex, regular tachycardia, and P waves, a question mark, definitely not sinus P wave, so equals SVT, okay? So it's a regular, narrow, complex, non-sinus tachycardia equals, in other words, SVT. So, often when you get tachycardia narrow complex, you don't think it's sinus. You want to give adenosine to stop the SVT. And then we give adenosine. Obviously, you have to give a good dose of adenosine with large flush or vagal, of course. And then you want to do recording during adenosine, by the way. I cannot stress this point any further. And then, before you do that, if you have good eyes, I mean, you wonder whether there's two P waves for every QRS. You wonder whether there's a sorry, P. You wonder, but maybe you're not super sure. You give adenosine, and then indeed you do see the sawtooth appearance of the P waves. In other words, the patient will
Yes.
flutter.
Flutter.
Okay, with 2-to-1 conduction. Okay. Okay. Versus ECG number 2. Can you describe ECG number 2, guys?
الصورة بس صغيرة أوي يا دكتور
I
محمد،
know,
الاي
I
سي جي
know. It's
صغير.
just one lead, but it's a narrow complex, right? Very
Yeah.
rapid. So narrow complex tachycardia is super rapid. It's like, maybe 250 beats per minute. So even it's just the rate is against sinus tachycardia. You cannot see P waves super duper clearly, but they're
اس
just
في تي.
rate suggest
بط.
SVT. Okay, you give it
عايزين نشوف.
and you terminate the rhythm into a PQRS rhythm that is with an arrow complex. So, another SVT, but in this case, it's not flutter. It's just AVRT or AVNRT that terminated with adenosine versus flutter. This is an example of flutter with unmasking of the flutter after adenosine. Okay. And then as you can see, during adenosine, there was variable conduction down to the ventricle. So sometimes flutter presents with regular tachycardia or irregular tachycardia, depends. Okay.
Yes.
Okay. And then when you terminate SVT, of course you want to assess see whether there's short RP, WW, delta, and then also you can clarify the RP interval like we said before. Anyways, okay, so just really quick, AVRT just means you're going down the AV node up an accessory pathway. This is called orthodromic AVRT. Sometimes it goes the other way around, but most commonly it goes down the AV node, up the accessory pathway. Hence, it's a narrow complex tachycardia because you're going down the AV node, engaging your hyperkinetic system. And the HF flutter just means there's a tachycardia that's rotating around if it's typical, around your tricuspid valve, and hence the AV node is not part of the circuit. So when you block the AV node, you just see the flutter waves without effect, without termination of the atrial tachycardia. Okay.
Yeah.
Okay. So for that, I mean, so since we're mentioning adenosine so often, it is really quick. It is given to regular tachycardia rhythms that are non-sinus. It could be therapeutic, it could be diagnostic, for example, during atrial flutter. You should avoid adenosine in irregular and polymorphic white complex rhythms. And then we will discuss why later, perhaps. And then adenosine terminates rhythms that involve the AV node, such as AV-NRT, AV-RT, or narrow complex rhythms. And if you have a wide complex rhythm, it might terminate the white complex rhythm if the white complex rhythm is because of an aberrantly conducted SVT or an SVT that is with a bundle branch block or antidromic SVT. And I'll describe this in a sec. I'll describe what I mean by antidromic SVT and aberrantly conducted SVT. So this is, you have a patient in SVT going down the AV node, up a left pathway, down the AV node. Okay. This is, like we said, this is an AVRT, SVT, and then when you give adenosine to this patient, the QRS, the tachycardia QRS is narrow, and then after adenosine, the tachycardia would remain the same. Okay, narrow complex, but sinus after adenosine, and prior to adenosine, you get narrow complex tachycardia, same QRS. Okay. Unless there's WW, in which you will get delta and widening of the QRS. Makes sense, guys? So when you get tachycardia, that is, narrow complex, you give adenosine, and then you terminate into sinus rhythm with the same QRS. This is, this confirms the tachycardia being supraventricular in origin. Okay.
Yeah.
Okay, so now imagine the same patient goes down, gets tachycardic, and then gets SVT, sorry, so goes down the AV node like before, but blocks in the left bundle. Okay, just the left bundle decided not to block conduction, so it goes down the right bundle and then eventually up the same pathway. Okay?
White QRS.
Yeah, so you will get wide QRS. You'll get tachycardia that is wide with left bundle branch morphology. Okay.
Yes.
So we call this AVRT with left bundle branch morphology. And then when you give it adenosine, it will terminate into a narrow complex QRS because the left bundle would work again, okay, during slow heart rate, unless there's a diseased left bundle, okay?
Yes.
Anyway, so the QRS would change from wide during tachycardia to narrow after adenosine. So this is how you can tell it was aberrantly conducted SVT. Make sense?
Yes.
Okay, unless you
Yes.
have baseline left bundle branch block disease. Okay, and then like we said, orthodromic tachycardia, it goes down the AV node up the pathway. Antidromic, you're going down the pathway up the AV node. So then with antidromic tachycardia, you'll get, of course, wide complex tachycardia because you're not going down the AV node, you're going down an accessory pathway, and hence you're not engaging the His-Purkinje system. Make sense, guys?
يعني الانتيدروميك يا دكتور محمد هتبقى وايد QRS.
طبعا, yeah, because you're going down accessory pathway. You're not going down your normal his. So in order to get
Yes.
narrow complex QRS, you have to use the his Purkinje system. If you're not using his Purkinje system, then you'll get wide QRS. Okay? So this is
يبقى لازم الانتيدروميك لازم معاها ليفت باندل برانش
لا, yeah, you're going
ولا لا؟
مو شرط. Depends where is your accessory
مم.
pathway. If it's going here or here, depends. If you're going
مم.
here, you get left bundle branch morphology. If you're going here, you get right bundle branch morphology.
مم.
Depends. Okay. If you for orthodromic SVT, it's the QRS is narrow. You give adenosine, the QRS remains narrow after termination. For
معلش يا دكتور محمد ايه اللي بيخليها تمشي انتيدروميك لو هي
It's
مش
just
ما فيش باندل
sometimes
برانش بلوك؟
sometimes it blocks the AV node and goes down the accessory pathway and then goes up the
اه
AV node.
بطريقة عشوائية يعني
ها؟
بتمشي بطريقة عشوائية
مو
فبتدينا
عشوائية
انتيدروميك.
يعني other way around. Just
Yeah.
rotate the other way around. It happens, just not
اه
very common. Okay. And then
اوكي.
QRS, so with this antidromic SVT, you present with wide complex tachycardia, you give adenosine, and then the QRS normalizes after adenosine if there's no bundle branch based on bundle branch block. Okay. There are
مم.
pathways that only conducts up to down or A to
مم.
V, and they usually present with only antidromic SVT because there's no other way for the pathway to work. Okay, so these are clear, guys. I know I might be a little bit too fast, but so stop me. I don't
مم.
talk for 1 hour and people get bored. So, guys, is it too easy, too difficult? ميرفت متولي سحر.
لا لا، بس بالراحة بالراحة يا دكتور محمد، ممكن ناخد حصتين عادي.
لا أنا I'm recording. I cannot say بالراحة because when I record I want to
اه
be شوية quick. Okay.
اوكي.
الانتي دروميك طب يا دكتور محمد
But you
هتبقى
can stop
نارو
me
كيو
يعني.
ار
It's okay,
اس؟
ها؟ شنو؟
لا الانتي دروميك نارو كيو ار اس برضو؟
No, antidromic is wide. Then you're going down an
اه
accessory
بس بعد
pathway.
افتر ادينوزين it will be نارو
Yeah,
صح؟
yeah. But you will see delta. You will see P, and then you have to see delta. Okay,
اه
delta QRS. It will narrow down, but not normal because there's delta because you have an accessory
اه
pathway.
اه
Okay,
ماشي
okay,
اوكي.
good point. Okay. Okay, so QRS narrower, but not normal because there's delta because you have an accessory path that
مم.
goes up to down. Okay. Okay. So versus apparently conducted SVT. Um, Um, so for example, you have this is a ECG for a patient who underwent AVSD repair. Okay. So when someone undergoes AVSD repair, would you expect bundle branch block? Yes or no?
VSD repair
Yeah. Yani
maybe
VSD closure. What might the patient get after VSD closure?
maybe heart
كومبليت
بلوك.
هارت بلوك.
No, no, I meant for bundles.
اه
Would the patient
for
get narrow? Yani would his sinus QRS would be narrow or wide often? After VSD closure surgery.
maybe white.
Yeah, they get what type of bundle branch block?
رايت عشان هو بيعمل
Right
رايت
bundle.
فنتريكولوتومي.
Yes, thank you. So they get right bundle branch block. Okay,
مم.
so that's a patient who went, after surgery went into tachycardia. Again, regular tachycardia. There's no P waves that you could appreciate, right? So no candidate P wave. So you say white complex tachycardia that is regular, not sinus tachycardia. Okay, so you have regular white complex tachycardia, not sinus. Okay, agree with this
مم.
description, guys?
اوكي little bit white بس مش عارف ال VRS
Yeah, white
duration.
had a baby. Yeah, you're talking 3 month old baby.
اه
Okay,
اوكي
that's definitely white for a baby. Okay,
اوكي.
4 month old. Okay, your differential would be VT, of course, but the other differential would be SVT with aberrancy, like we just said, or antidromic SVT, right?
مم.
Let's say you don't have a previous ECG, so you don't know whether it has WW or not. These are your differential, okay? SVT with aberrancy, antidromic SVT, or VT, okay? So because it's regular rhythm, despite it being wide, you can still give adenosine, like we said before. So we gave adenosine,
yeah
okay, and then the tachycardia terminates, right? It terminates into what?
heart block شكله heart block 2 to 1 ولا ايه؟
Yeah, look carefully. So that's
مم.
what? What's this?
مم.
What's this? P, right?
retrograde B.
Well, it's upright in lead one, lead two, not
موبس.
AVL positive, AVF positive. So, sinus P, right? Most likely, right?
وده
صح.
ريجولار ار ار.
Yeah, I mean,
looks
post
في dropped
adenosine, of
beat يا
course.
دكتور
Yes,
محمد.
guys, this is
شكلها في
post
dropped
adenosine.
beat.
Guys, this
مم.
is post adenosine, right? So the
مم.
patient was tachycardic, you suddenly stop the tachycardia. You don't expect immediate regularity of your sinus rate, right? So there's a
مم.
P wave, PQRS, T. P looks sinus because positive in lead one, positive in lead two, positive in lead AVL, positive in lead AVF, most likely sinus, okay? So P,
مم.
QRS, T, P, longer PR interval, QRS, T, P, QRS, T, P. The point is, did you terminate the tachycardia, yes or no?
yes.
يس ترمينيتد.
Yes. Is it VT, yes or no?
لا is it ايه دكتور محمد
VT,
معلش؟
VT. Is it VT?
ventricular? No.
No, صح?
لا لا لا
Because adenosine responsive. Most
سوبرا
likely,
سوبرا فنتريكل.
it's not VT, okay? Okay, the QRS plus the QRS, this QRS, is it identical to the tachycardia QRS? So when you're in sinus,
No,
the
it's wide.
QRS is it
Wide
identical to your
QRS.
tachycardia QRS? Is this QRS identical to this QRS?
This identical. This
Yes.
one identical to this.
This is again against VT because the VT should be different. Your QRS should be different during tachycardia and during sinus. صح? صح?
Yes.
Okay. Antidromic as SVT. We said you should expect wide change to narrow. صح? And there's delta wave. Do you see delta wave or wide changing to narrow?
لا.
No. فit's not antidromic SVT. صح؟ صح؟
يس.
صح.
الكيور اس زي ما هي.
Yeah, فبقى SVT with aberrancy, right? So then it was an SVT because the sinus QRS is identical to the tachycardic QRS, so that's SVT by definition, okay? But it's SVT with aberrancy because the sinus QRS is right bundle branch block, okay? So there's SVT with aberrancy post-surgery, okay? So we rule out VT, we rule out entropic tachycardia, we ruled out aberrantly conducted SVT that with a normal, with a normal baseline, but we identified an SVT with aberrancy with a baseline bundle branch block. Okay, make sense, guys?
يعني الواحد
طب احنا
كونفيوز
ليه ما
شويه.
قلناش عليها جنكشن تاكيكارديا الاولانيه قبل ما ندي ادينوزين؟
Junction tachycardia, junction tachycardia will it terminate with adenosine?
نو قبل ما ندي الادينوزين.
Yeah, of course you can. Sure, it could be differential. Yeah. You mean you can add junction tachycardia here? Yes, sure, we can add junction tachycardia here. We can add junction tachycardia. حاضر. Okay, junction tachycardia. Okay, could be طبعا. Could be. Okay, but again, adenosine should not terminate your junction tachycardia. Okay? Okay?
Yes.
Okay. انزين. But anyway, so this patient had the baseline right bundle and went into SVT. Okay? Okay. Anyways, so that's another case, 10 years old, who presented with white complex tachycardia a couple of times before. Never had an narrow complex tachycardia, always white complex tachycardia, but terminates with adenosine. Okay? It's a difficult ECG. It's not, I mean, if you look carefully, you wonder whether there's a delta wave that is very subtle, PR, borderline, again, delta wave that's very subtle, difficult
يس.
difficult to say. But then when you see this delta, when you see subtle delta and you see patient going into tachycardia that's always white complex, of course you should think of antidromic SVT.
سوري.
Antidromic SVT, okay? A tachycardia that goes down the accessory pathway and up the AV node. Because always white complex tachycardia, then antidromic SVT is a differential. And then there are accessory pathways that are only conduct antigrade, meaning A to V, but don't conduct V to A. So if they will get tachycardia, it's always white complex tachycardia. Okay, and this patient was indeed one of them. He underwent EP study, and there was always white complex tachycardia because the circuit goes down the down the accessory pathway, up the AV node. Okay, this accessory pathway cannot conduct V to A, only conducts A to V. So if there would be tachycardia from that accessory pathway, it will always be white complex. Okay, it's a complex, complex ECG or complex case. This is called Makaim tachycardias. But anyways, just so you know, this is an example of antidromic SVT. It's not very common. Okay, and this is my only example. Okay. Okay, so really quick with adenosine, you might get no effect if the delivery is poor, if the dose is inadequate, or if there's VT, you might have, if you have gradual slowing and a reacceleration with sinus tachycardia, sometimes tachycardias behave as such. But if you have sudden termination, AVNRT, AVRT would terminate your tachycardia. And then rarely tachycardias would terminate with adenosine. It's not very common. And then, if you have if you see persistent P waves, tachycardia P waves that are marching through, and then you block the AV node, so you can unmask your atrial tachycardia, or you can unmask your atrial flutter. Okay, so adenosine is very helpful to unmask atrial tachycardias or atrial flutter, or to terminate AV NRTs and AV RTs. Okay, guys. Okay, so that's one
Okay.
example of a patient who had, tachycardia as such. If you look at it, I mean, it looks like a sinus tachycardia. He was 7 months old, who was like 170 heart rate, roughly, resting, sleeping, not in distress, but heart rate above what you would expect. Okay, so. But then if you look at the P waves, you wonder it's just sinus tachycardia, but there's no explanation for that sinus tachycardia. Plus, the PR, the P wave looks a little bit, generous, and the PR looks wide-ish for a baby who's tachycardic. You would expect when someone's tachycardic, the PR shortens, okay? So, was a question mark atrial tachycardia that is similar to sinus tachycardia. We gave adenosine, and as you can see, the the P to P, P, just goes, the P to P, the P's are persistent, but there's block in the AV node, and then you can see them better. Okay. Anyway, so that was a baby who we thought was having persistent atrial tachycardia. Okay, and adenosine helped us a little bit. Okay. Anyways, so back to our, algorithm. So tachycardia, that's narrow, either sinus or SVT. If it's SVT, it could be regular or irregular. And if it's regular, we said AVNRT, AVRT, or flutter with to a fixed conduction. But if it's irregular, you should think of atrial tachycardias, atrial fibrillations, flutters, or jet or junction tachycardias, usually irregular. Okay. Okay. So that's a 5 years old patient who had like incessant tachycardia with a little bit of cardiomyopathy. As you can see, always had regular rhythm on examination. This is in fact how he presented, or how he was referred to us. And then you can see the patient has like, for example, this is P positive in lead 1, 2, 3 AVF. But then, perhaps sinus P wave, but then goes into rapid, heart rate, and then stops, and then sinus P wave, but then rapid few beats of tachycardia, and then stops, and then, so forth. Okay. So that's a behavior of an focal atrial tachycardia. The P waves are not identical to the sinus P waves. I mean, they're very similar, but not identical, okay? Because the origin of that patient, atrial tachycardia, was near the P wave, near the sinus P wave, okay? If you look at lead 1, for example, the tachycardia P waves are very tiny, very small versus a bigger sinus P wave. Anyway, so this is how I would describe the CCG, not a
Can't
complex.
call it يا دكتور محمد 6 sinus.
No, 6 sinus means you are bradycardic, okay?
Mm.
This is a patient who has a normal sinus, but is perpetuated by a focal frequent atrial tachycardia. Okay, so that's a narrow complex, a regular tachycardia, non-sinus P wave, 1-to-1 QRS ratio. So again, it's an SVT. Okay, there's an SVT that's non-persistent. Okay, but frequent. Okay, and then if you look at the RR intervals or the PP intervals, a little bit irregular. Okay, so this patient underwent ablation, and there was an abnormal origin of his P waves up near the SVC-RA junction, and then was ablated at this location, and the function normalized slowly thereafter. Okay, okay. And this is a patient we just seen like a couple of weeks ago. He was a 12 years old patient who had history of hypertrophic cardiomyopathy, obstructive hypertrophic cardiomyopathy, presented with palpitations, and then this was his ECG, and then
atrial flutter.
well, okay, I mean, it's irregular, right?
Yes.
And then if you look at the P waves
narrow
very well,
complex.
narrow complex irregular tachycardia. If you look at the P waves very well, I mean, they are a little bit different. This P wave is a little bit different than this P wave, صح?
Yes.
This is more fibbish, okay? So I would call this atrial fibrillation. So narrow, complex, irregular tachycardia, non-sinus P wave. Definitely P waves are very fine, multiple morphologies, more P's and QRSs. So SVT, not sinus, but irregular, more P's and QRSs. So you're talking atrial fibrillation or atrial flutter or atrial tachycardia. But you know, more AFib looking, okay? Very rapid atrial rhythm and fine irregular atrial rhythm, okay? So the patient, if you remember, we cardioverted the patient and we are recommending, because he has severe obstruction, so he probably will undergo surgery. And then in the meantime, after surgery, we'll see whether, how he would, behave, okay?
Finally, this is AFib, not
Yeah, it's AFib.
flutter.
Then irregular, well, P waves are different morphologies. Okay, flutter should have fixed, يعني should be, should have, should have P waves that are identical, like this example we showed before. Remember, this one. This is flutter. Okay, PP regular, same P wave. Okay,
Yes.
okay.
Yes.
This is fibbish, atrial fibrillation. The other one. Okay. Anyways. Okay. 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 Another case, 8 years old, who had presented with
White
palpitation,
complex.
pale, very rapid heart rate. So it's a white complex,
VTAC.
irregular, صح? Just say white complex irregular rhythm.
بس monomorphic.
Polymorphic.
Looks
No,
monomorphic.
no, it doesn't look monomorphic. If you see
شوية.
QRS is different, صح? You
مم.
see here different than here. This one is different than this one. It's a little bit this one. You see this one is different. Okay. I know it's grossly maybe monomorphic, but definitely if you look very closely, it's polymorphic. So irregular,
Yes.
white complex, polymorphic tachycardia. So VT until proven otherwise, of course.
Yeah.
But the patient suddenly, with vomiting, tried to vomit by himself or herself, and then rhythm changed suddenly, and then the ECG just changed suddenly into this rhythm. So what do you guys see here?
Maybe لا here ولا اللي فاتت؟
Yeah, here.
Here.
اليوم
This is delta wave.
only
This is
Yes.
delta wave.
Yeah. So there is a short
Mm.
PR with delta wave, صح? So there's WW, right?
Mm.
So now knowing this,
Yeah.
knowing the patient had WW,
Yes.
what is this now? Is it still VT or is it something else? Most likely.
Most likely was apparent SVT was apparent here.
Asymptomatic.
It's atrial fibrillation with aberrant with WW, right?
Atrial
Atrial
fibrillation.
fibrillation with
Uh,
WW. Okay, so that's as a
Mm.
cardiologist, you have to recognize this. So WW patients, they might have risk of sudden death because of this. Because they get AFib more than the general
AFib.
public. And then the AFib, conducts rapidly down the accessory pathway into the ventricle, and they get rapid ventricular rates, and this predisposes them to ventricular fibrillation. Okay, this is why WW patients, we recommend ablation to avoid sudden death. Okay, so this patient presented with a rhythm that is life-threatening. Okay, and was found to have an accessory pathway, and so the initial diagnosis was perhaps VT, but then we know it's not a VT, it was an accessory pathway, WW, sorry, patient with who had AFib going down the accessory pathway, which with an ECG that looks similar to polymorphic VT. Okay, so
عشان كده الادينوزين هنا ما بنتاخدش يا دكتور محمد.
yeah. So this is why you should not give adenosine to
Adenosine not given here.
who
Yes.
has a regular rhythm, because if he's in a pre-excited AFib or WW with atrial fibrillation, you might further risk ventricular fibrillation. Okay. Okay. So anyways, okay. So anyways, more ECG hints that favor specific SVT types. Onset is very important, and I always tell you guys, if you have onset, get it. because like we said, sudden onset,
sudden. Mm.
sudden versus gradual onset, it helps us differentiate atriotacardias or AVRT or AVNRT. Of course, if the onset with the PVC, then atriotacardia is unlikely because they are two different chambers. Okay. If the termination is sudden, it goes more with AVNRT, AVRT. If the termination is gradual, it goes more with automatic tachycardias or SVT, or sinus tachycardia. This is something that you should you might not be you might not know it, but it's good to know. If the termination of the tachycardia, for example, this is an ECG of a patient who's tachycardic, and then P wave that's negative, okay, QRS T, P negative, QRS T, okay, terminates with a P wave. Here, this is the termination. Of course, then it terminates and then goes back to sinus, okay. So if you terminate with a P wave, then you block down the AV node and then it terminates, right? So if this repeatedly happens, then it's against atriotacardia, because why would an atriotacardia stop if the AV node blocks it? Okay, atriotacardia doesn't care about the AV node, صح? If you have a patient who has it's a long RP tachycardia like this case, okay, and terminates with the atriotacardia is a differential, of course. And if it terminates with a P wave, then atriotacardia is less likely, because it just tells you that the AV node is part of the circuit, because whenever the AV node blocks, the tachycardia stops. Make sense? Well, I repeat this.
بس
My-
يعني الاتريا تاكارديا مش
يعني
هتوقف مش
يعني
هتبلوك
if you have an atriotacardia, suddenly you block
الويف.
the AV node. Would the tachycardia care about the AV node or would not?
نو نو.
No, صح. If you have focus in the area that is firing, the AV node
يس.
is part of the circuit. If you block the AV node, for example, by giving adenosine, the tachycardia will still keep going. Okay? But if you have a tachycardia that terminates with a P wave, then this is against atriotacardia. And if it's long RP tachycardia, like we said, there's differential, includes atriotacardia, PGRT, atypical AVNRT. Then if you just by observing this, it's not atriotacardia then, and so differential is even further narrowed down. Okay? I mean, this is probably advanced. It doesn't, you don't have to worry about this. So that's, if you remember, I showed an atriotacardia patient before, and then if you noted the QRS, the rhythm terminates with the QRS, right? So you said sinus P wave and then burst of tachycardia, but there's no P at the end, So that's more typical of tachycardia. This tachycardia decides to stop, goes down the QRS, but then that's it, okay? So termination of the rhythm is also important to figure out type of SVT, okay? Okay, and then we said if the P's are equal to the QRSs, then you study the RP interval. If the P's are more than QRSs, then it's tachycardia, atrial fibrillation, atrial flutter, not AVRT, okay? AVRT, because A and V are in the circuit, it has to be 1-to-1. There has to be 1-to-1 ratio for AVRT, okay? So that's an ECG example of a patient who's having multiple P waves for every QRS or more per QRSs. So that's it's atriotacardia flutter case, okay? If you have more QRSs than Ps, but the QRSs are narrow complex, then this is JET, okay? Junctional tachycardia, okay? Make sense, guys? So this is what we see in the post-op patients. You get narrow complex tachycardia, but more QRSs than Ps. Then this
يعني البي ويف نوت كلير،
مو بس not
هتبقى الكيو ار اس اكتر.
مو بس not clear. If you مو not clear, no. If you are certain there's more QRSs than Ps, for example, when you do atrial ECG, you know where are P waves. So if the QRSs are more than the Ps and the QRS is narrow or the usual complex for the patient, exactly like the sinus QRS, then by definition this is JET, okay? So you have a supraventricular tachycardia, but coming from the AV node, okay?
يعني مش تبقى 1 to 1، مش تبقى 1 to 1.
Usually, it could be 1-to-1, but usually it's more QRs than Ps, but it also could be 1-to-1, yani. Okay. 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 So, so actually, this is a JET patient. This is not post-op, this is a congenital JET patient. So as you can see, it's a complex ECG. You can see in general, it's a narrow complex tachycardia, okay? Irregular, صح? And then if you look at the P waves, this is a P wave, okay? This is a P wave. This is a P wave, صح? This is a P wave,
Yes,
صح?
yes,
The
ماشي.
P wave.
Okay.
So, for example, which one is more, QRS or Ps?
هنا QRS
QRS more.
يوريس
في
And the
في 2
QRS,
cycles كده ما فيهاش
yeah.
بي.
And the QRS is very narrow, almost identical to sinus QRS, صح? صح? That QRS is identical to this QRS almost, صح? Very narrow, okay? But that's junctional tachycardia, okay? The patient who, I don't know whether you know this family, it's a family who has a patient with repeated visits to our clinic with junctional tachycardia. Okay, it's a congenital junctional tachycardia. Junctional tachycardia is usually post-operative, but there is also congenital form of junctional tachycardia. Okay, so you get fast rhythm, of course, irregular typically, and then you get more QRs than Ps. You get something called sinus capture beats. You get AV dissociation. Okay. Okay. AV and RT, by the way, typically 1-to-1 QRS, but sometimes it's not. Okay, but typically 1-to-1. But I'll not discuss this
بس
further.
هنا الإيدج how
It was like
how much
less than 1 year. Small, يعني.
لسه بس.
Yeah.
طب والهارت ريت
Well, he
أنا
was.
شايفه
This is before
3.
treatment. I mean, we treated him. He's okay, but he's not coming to
مم.
clinic very often. But he's still okay-ish.
مم.
He
مم.
comes every now and then. After the medications are
مم.
stops, and then they stop for a couple of weeks. He gets tachycardic, and then they
مم.
come to clinic. They're not very compliant family. Okay. And so I mentioned capture beat, which just means there's a conduction of an atrial P wave or impulse to the ventricles when the predominant rhythm originates not in the atria but in the AV junction or the ventricle. This is the definition of capture beat. Okay. Or another, to simplify things, the P wave temporarily captures the ventricles, shortening your aura interval. So, for example, this is your tachycardia rate. Suddenly, there's an early QRS preceded by a P wave. Okay,
مم.
so this P wave most likely captured the ventricle in a rhythm that is not that predominant rhythm is junctional or ventricular. Okay, this is called capture beat. Okay, and then this is seen in VT or junctional tachycardias. Okay, anyways, that's more this is advanced, advanced level slides. I don't think you have to worry about it. Anyways, so other maneuvers in your, in your arsenal that you can use, if you have a post-operative patient and you have pacing wires, you can rapidly atrial pace a patient, and you can terminate SVTs that are AVRT in origin, AVNRT in origin, or flutter. Okay, but you have to pace faster than the atrial rate. Okay. But you cannot terminate jet or tachycardia. You can override them. You can just be faster than them and control the rhythm by pacing faster than the focal tachycardia. But you cannot once you stop pacing, it will come back. Okay. Versus shockable rhythm, so you can shock the patient and see the response, or if the rhythm terminates after shock, this is could be AVRT, could be AVNRT, could be flutter. And there also could be atrial fibrillation, but it's usually ineffective in atrial tachycardia or junctional tachycardia. Okay, so the behavior of the pacing maneuvers or the shocking or the cardioversion helps you also figure out the SVT mechanism. Okay, understood, guys? This is why post-operative patients, I never say just shock the patient. Okay, I never say give adenosine because it doesn't respond to shocking or adenosine in jet, for example, but it responds to atrial pacing. You can pace faster to override the rhythm to get synchrony. Okay. So what our algorithm is getting more and more complicated. So we said tachycardia, narrow, sinus or SVT, regular or irregular. Okay. If it's wide, then you can classify wide into regular or irregular, of course. And regular is usually monomorphic, and then it could be, of course, sinus tachycardia with bundle branch block, or could be SVT with bundle branch block, or could be antidromic SVT. Okay, it's regular. This is SVTs. Antidromic SVT is regular, and or AVRT, AVNRT with aberrantly conducted is usually regular. Okay, if it's irregular, could be atotachycardia with aberrancy or AFib with WW. Okay, تمام. Makes sense, guys. Algorithm, does it make sense to you? Well, it doesn't. If it doesn't, you have to stop me and ask me a question.
لا where is the VTech هنا؟
We're not talking about VTAC, we're talking about SVTs today. Okay.
ماشي
طبعا
عشان
VTAC is a
بس
wide complex rhythm. Then of course VTAC is in your differential, but I'm not talking about.
yeah okay
I mean, then you guys would be. It's too much in one session. Okay. Okay. So onset, termination, RP interval, whether there's AV dissociation, PQRS ratio, adenosine response, shocking response, pacing response, all are helpful to further figure out the SVT mechanism. Okay. Furthermore, when you look at the P wave, axis of the P wave also helps. It's very helpful because when you have accessory pathway, like we said, you're going down the AV node, صح? Up a pathway, صح? You're going down the AV node and then up a pathway, صح? Okay? So you're going up.
yes
Okay? You're going, usually axis of the P wave usually would be superior. Okay? You're going from down to up. Okay? So down to up. You're going يعني from your AV node up your atrium. Okay? So you're going, usually the P wave would be negative in your inferior leads. Okay? You're going away.
This is an accessory busway.
If you have accessory pathway or AV and RT, okay, you're going.
DV entrant?
Yeah, I mean, it could be random, but anyways, if you have an accessory pathway, yes, accessory pathway or AV NRT is usually reentrant. Okay, so if you have an accessory pathway or AV NRT, you're going up the atria. Okay, so the axis, so the P wave would be negative in 2, 3 and AVF. Okay, so you're going away from your inferior leads. So when you see the P wave being negative in 2, 3 AVF, this might be a hint that it is an accessory pathway or AVNRT. Could be a tachycardia that's coming from down as well. Okay, so it could be many things if it's inferior, if the P waves are negative in 2, 3 AVF. But if the P wave is coming from up top, okay, you'll get P wave that is positive in lead 2, 3 and AVF. Okay, so now you're going, the P wave is coming from up top down to the AV node, صح? But that's definitely against AV NRT and AVRT and suggests more atotachycardia. Okay, so the P wave, whether it's positive or negative in 2, 3 AVF in the inferior leads, it might be helpful to figure out whether it's an atotachycardia or not. It might be helpful. Not always helpful, but might be helpful. Okay. Furthermore, when you have a you have a wide complex rhythm and then goes down to narrow complex rhythm. So for example here, okay, you have wide QRS, goes down to narrow QRS. Okay, that's 6 years old with frequent SVT. Okay. Sorry. So I mean that's a P wave, PQRS, and then there is this T wave is different than this T wave. So there's probably a PAC that started the tachycardia. Okay, so started with a PAC. It's very regular. Okay, here you don't have markings, but this looks very regular. Okay, and so sudden onset, sudden termination. So re-entry regular. Narrow complex or orthodromic. So initial white complex is is bundle branch block, but then normalizes into narrow complex. So that's it's okay to have an initial wide QRS that goes down to narrow QRS. This is common. Okay. So when you get the tachycardia that's wide and goes down to narrow, this is SVT. VT doesn't narrow down, of course. Okay. Okay. And then termination here, if you see the terminates of the P wave. Okay. And then this is against atrial tachycardia. So that's an example of an SVT that's re-entry, not atrial tachycardia SVT. And then when he went to the cath lab, indeed, he had an accessory pathway SVT. Okay. That's another example of a wide complex onset with a wide complex and then narrows down to narrow complex. Okay. It's a complicated tracing, but the point is now wide to narrow is SVT, not VT plus SVT. It's unusual. Terminates with the P wave is against atrial tachycardia. Okay. And so forth. So another example of an accessory pathway mediated tachycardia, or not atrial tachycardia, but re-entry tachycardia, but that's not atrial tachycardia because it terminates the P wave. Okay. And sudden onset, sudden offset, regular. Okay. Okay. So I was trying to say is wide complex going down to narrow complex, same tachycardia is usually SVT with and without aberrancy. Okay. If it terminates the P wave, then it's against atrial tachycardia. And then if you see cycle length changes during wide and narrow, this tells you that the ventricle is part of the circuit. Okay, this is too advanced. I don't know whether you have to worry about it. This is a too advanced slide as well. But um, uh, and then I'll just say a few more slides. The atrial wire is another important tool that you could use to help you figure out the tachycardia. So that's an ECG of a patient who had post AVSD repair, okay, and who is tachycardic and not super wide complex, of course. I mean, luckily for the patient, did not have right bundle branch block, probably partial AVSD, probably. Anyways, but definite tachycardia, there's no P wave, صح? So narrow complex, regular tachycardia, EC left axis because of the AVSD, صح? Okay. Okay. So you don't know where the P waves, you can use your tool, you can see atrial, I said definitely. I mean, if you look very carefully, you wonder where there's a P wave here, but very small P wave, you don't know. You can use your atrial wire, and then indeed, when you use the atrial wire, the P waves are augmented. You see, now you can see P waves, okay? So then there was indeed P wave that is here that you could not see, maybe because there's atrial swelling, patient underwent surgery, there's edema of the atria, so the P waves are not very well seen. Atrial tissue is diseased. But anyway, so in retrospect, initially we thought it's SVT, but when we did atrial wire study, it was actually perhaps just sinus tachycardia. Okay. So atrial wire helps. Another example, so not very clear tracings, but post-op tetralogy patient who's tachycardic, wide complex because he had right bundle branch block. If you look very carefully, the P waves are not very clear. You do atrial wire, and then you see there is the T wave. If you see the T wave, there's a peaked signal at the tip of the T wave. That's your P wave for this patient. And then so there's QRS 1-to-1 QRS P ratio. So it could be sinus tachycardia, or it could be just junctional with retrograde P wave. You cannot tell because the atrial signal it's not P waves, it's not your ECG, it's just atrial signal. So at least you ruled out flutter, for example. Okay. So that's helpful. And then when they pace here, what are they doing? What's this, guys? Same patient, huh? What are they doing here? There's something PQRS, something PQRS. What's happening here?
sinus.
Well,
This
what
is
comes?
atrial pacing.
Yeah,
Atrial
they're
pacing.
pacing. They're trying to override the junctional tachycardia. So they're pacing faster than junctional tachycardia. And then you can see the QRS is identical to the QRS here. So this is, yes, it's wide, but it's not VT because when you pace A and goes down the V, and the QRS is identical here versus here, you know this is not VT. Okay. لأن you know how the QRS of the patient should look like when you're engaging the A. Okay. So it's a wide complex regular tachycardia, no obvious P waves. We did HOR study, we saw 1-to-1 PQRS ratio. It could be jet, it could be sinus tachycardia, difficult to tell. But anyways, with atrial pacing, we override the rhythm. With a similar QRS, at least we ruled out VT. Okay? Makes sense, guys? So HOR is very helpful. Okay? So in summary, we talked about onset, termination, RP duration, dissociation, PQRSs, PQRSs, P-wave axis during tachycardia. We talked about QRS axis. And, when you get aberrantly conducted SVT, usually you have typical bundle branch block. بمعنى you have normal axis with right bundle, or maybe rightward axis with right bundle. Usually you have left axis with left bundle. These are your typical patterns, okay? And then the PR, we talked about the PR being short in sinus tachycardia versus a little bit longer than in atrial tachycardia, and so forth. Okay, so to summarize, narrow complex tachycardias could be regular. If it's regular, you study the P waves, and then if the P waves are more than the QRSs, then it's either atrial flutter or tachycardia, or atrial tachycardia, or atrial, well, not fibrillation because it's regular. If the tachycardia is not regular, then you think of atrial fibrillation, atrial tachycardia, flutter with variable AV conduction, multifocal atrial tachycardia, and so forth. If it's regular without visible P waves, then you think more of AV NRT and AVRTs, and then if it's visible P waves but with 1-to-1 QRS ratio, you study the RP interval. And then, like we said, RP interval, if it's short, it's more AVNR, typical AVNRT, AVRT. If it's long, it's more PGRT, atypical AVNRT, and atrial tachycardia. So that's summary of what we said today. I know it's too much information, but I cannot, I wanted to know how long does it last, for me to talk about all these slides. So it's, I don't know how long did we last, but we lasted quite a bit, يعني.
Yeah.
It's recorded, so you can, study it. But any questions that you want to ask, like really quick?
شكرا دكتور محمد.
متولي تعقدت ولا متولي اوكي؟
شكرا
لا
دكتور
كويس.
محمد.
حضرتك بس ستوب
continue.
الريكوردينج
إيه.
دكتور محمد.